Welcome to the Deep Dive. Here, we take the sources you provide and, well, we dive deep, pulling out the essential info you need, quickly.
That's right. And today, our focus is squarely on chronic pancreatitis, using a set of revision notes someone sent in.
Exactly. So maybe you're prepping for an exam, need a quick update for work, or perhaps you're just curious about how the body works, or sometimes doesn't work so well.
Our goal is to give you a solid, but, manageable understanding of what can be a pretty tough condition.
We'll be covering quite a bit: the definition, what causes it, the risk factors.
How it actually develops inside the pancreas, how doctors diagnose it, manage it, and, importantly, the potential complications down the line.
It's definitely a challenging condition, no doubt about it. But stick with us, we'll piece the picture together.
Okay, so starting right at the beginning, pancreatitis. It's inflammation, right, of the pancreas.
Yeah, that organ kind of tucked away, doing vital work with digestive enzymes and insulin.
Yeah, absolutely. Those enzymes are like little helpers breaking down food, and insulin handles your blood sugar. Crucial stuff.
So what makes chronic pancreatitis different from just, a one-off acute attack?
Well, the key word is chronic. It means the inflammation sticks around, it's long-term. And this isn't just temporary irritation, it leads to permanent damage.
Permanent damage, meaning the pancreas gradually stops working properly.
Exactly. Loss of function. This often means people need to take digestive enzyme supplements for life sometimes.
Wow. And maybe even surgery.
Surgery can definitely be on the cards in some cases, yeah.
Okay. And the notes mention some triggers straight away, things like heavy drinking.
Alcohol is a big one, yes. Also autoimmune problems where the body attacks itself.
And genetic factors, too, like cystic fibrosis.
That's right. Cystic fibrosis is mentioned. It really seems like pinning down chronic pancreatitis can be quite the diagnostic journey.
A real medical detective story, as you say.
It really can be. Diagnosis isn't always simple, and managing it has its challenges. And the link between an acute episode and developing the chronic form, well, it's not always clear-cut.
So you don't always get acute attacks first.
Not necessarily. Sometimes chronic pancreatitis just kind of develops more sneakily without that obvious history.
And the notes pointed out something quite striking about diagnosis time.
Ah, yes. The calcification. Those little calcium deposits in the pancreas.
Yeah.
A real sign of long-term damage.
They might not even show up on scans for how long?
5 to 10 years, sometimes even longer, after symptoms have already started. Think about that delay in getting a clear picture.
That's a huge lag. Okay, let's really get into the why. The etiology section in these notes seems pretty thorough.
It is. And it's important to remember, some things cause acute pancreatitis.
Yeah.
But if those triggers keep happening or the damage is ongoing, that's what can lead to the chronic state.
Right. Makes sense. So the general list includes...
Well, the big two are often gallstones and alcohol abuse.
Yeah.
But also certain medications, high triglycerides, that's fat in the blood.
Yeah.
Infections, those autoimmune disorders, again, genetic factors, and even, physical issues with the pancreas or its ducts.
And drilling down specifically into chronic pancreatitis, what else is listed?
Beyond those, the notes mention biliary tract disease problems with the bile ducts. Also, iatrogenic factors.
Iatrogenic, meaning caused by medical treatment.
Exactly. The example given is ERCP, that scope procedure used to look at the bile and pancreatic ducts. It can sometimes, unfortunately, trigger pancreatitis.
Okay. What else?
Metabolic disorders pop up again, like high triglycerides or high calcium levels. Trauma to the abdomen is another one.
And congenital disorders. Cystic fibrosis again.
Yep, CF is mentioned again there. And surprisingly, quite a range of drugs, is athioprine, sulfonamides, loop diuretics, or examples given.
And then there are the cases where the cause just isn't found.
Right, the idiopathic cases.
Yeah.
Frustrating, but it happens. They're split into early onset and late onset. And finally, abdominal radiotherapy is on the list, too.
It's a really diverse group of potential causes. It shows how many ways the pancreas can be, well, upset long-term.
It really does.
So what makes certain people more likely to actually develop chronic pancreatitis? Moving on to risk factors.
Well, a lot of the causes we just talked about are also risk factors, naturally. Gallstones, alcohol, obesity, smoking.
Smoking, too.
Definitely. Certain medications, family history is important, high triglycerides, infections, trauma, autoimmune diseases, they all contribute to risk.
But are there factors that really strongly point towards the chronic form developing?
Yes, the notes highlight a few key ones. There's a very strong link. Something like 60 to 70% of chronic cases tied to significant alcohol abuse over, say, 6 to 12 years.
That's a pretty stark connection.
It is. But crucially, the notes also stress that smoking is an independent risk factor. Even if you don't drink heavily, smoking increases your risk.
Okay, that's important. And genetics play a role here too, you mentioned.
A significant role.
Mm.
The notes name specific genes. GGT1, CFTR, the cystic fibrosis gene again, and SPINK1. Variations in these can make you more susceptible.
So it's like a genetic predisposition.
Exactly. The notes called it a complex interplay of genetically induced metabolic changes. Basically, your genes might deal you a hand that makes you more vulnerable if other risk factors like drinking or smoking are present.
So it's a mix of lifestyle and genetics. Makes sense. Okay, let's get into the mechanism, the pathophysiology. What's actually going wrong inside the pancreas?
Okay, so fundamentally, in any kind of pancreatitis, the basic problem is that digestive enzymes get switched on too early, inside the pancreas itself.
Instead of in the intestine where they're supposed to work.
Precisely. So they start digesting the pancreatic tissue, self-digestion, basically, leading to inflammation and damage.
And in chronic pancreatitis, this just keeps happening.
Yes, it becomes a persistent cycle, and this leads to specific issues. The notes mention obstruction of bicarbonate excretion.
Bicarbonate, that neutralizes acid, right?
It does. So if that's blocked, things get more acidic, potentially worsening damage. Then there's the enzyme activation causing necrosis, tissue death, and fibrosis.
Fibrosis, that's scarring.
Scarring, exactly. Over time, scar tissue replaces healthy pancreatic tissue, and it just can't function properly. Genetics, as we said, can contribute to all this.
And alcohol's role.
It seems to be twofold. It can cause proteins to clump together, forming plugs that block tiny ducts.
Mm-hmm.
Plus, alcohol is directly toxic to the pancreatic cells.
Like a direct poison.
In a way, yes. And then there's oxidative stress. Think of it like biological rusting that also contributes to the ongoing damage.
Quite a destructive process. The notes also mentioned large duct versus small duct, chronic pancreatitis. What's that distinction about?
It's mainly based on what's seen on scans, particularly the main pancreatic duct.
Hmm.
In large duct disease, that main duct looks widened, dilated.
Okay.
This type is often linked with steatorrhea, that fatty stool problem, and might be more suitable for surgical approaches to unblock the duct.
In small duct.
That's more common in women. Often the scans look, well, normal, especially early on. Management there tends to focus more on enzyme replacement therapy, PETA, because there isn't an obvious large blockage to fix surgically.
So it guides the treatment path. Makes sense. Are there also specific types of chronic pancreatitis identified?
Yes. The notes detail three main ones. First, hereditary pancreatitis. It's rare, caused by a specific gene mutation, PRSS1.
Okay.
Usually starts early in life, lots of pain, problems with both digestion and blood sugar, and importantly, a much higher risk of pancreatic cancer later on.
That's serious. What's the second type?
Tropical chronic pancreatitis, found more in tropical areas, affects younger people. It's a bit like the alcoholic type, but often involves large calcium stones, calculi, in the pancreas. High diabetes risk, too, and linked to gene mutations, especially noted in Japan.
Interesting geographical link. And the third?
Autoimmune chronic pancreatitis. Here, the immune system itself attacks the pancreas. There's a type 1, more common in Eastern countries, and type 2, more in the West.
How's that diagnosed?
Often by high levels of certain antibodies, like gamma globulins and IgG.
Yeah.
The good news is it often responds well to steroids.
But there might still be a cancer risk.
There's a possible link, yes, even though long-term survival is generally better than other types. But maintenance therapy might be needed. So yeah, each type has its own distinct features.
Okay, so the causes and the how are clearly complex. When someone comes in with symptoms suggesting pancreatitis, what else do doctors need to rule out? The differential diagnosis.
Right. Especially for an acute attack. The list is quite broad because tummy pain can mean many things.
Like what?
Well, common things like gastroenteritis, stomach ulcers, gallbladder inflammation, cholecystitis, but also more serious stuff like acute hepatitis or even a leaking abdominal aortic aneurysm.
Wow, okay.
And sometimes the cause isn't even in the abdomen. A heart attack or pneumonia can sometimes present with abdominal pain.
So you have to think widely. What about if imaging shows those calcifications we mentioned? Is it always chronic pancreatitis?
Usually a strong pointer, especially with symptoms, but the notes remind us of other possibilities. Severe protein malnutrition can sometimes cause it. Yeah. And hereditary pancreatitis, which is a type of chronic pancreatitis anyway. And hypoparathyroidism, overactive parathyroid glands, leading to high calcium, which can deposit in the pancreas.
Good to keep those in mind. Now, how common is this condition? The epidemiology?
The notes give UK figures. Incidence, new cases per year, is roughly 15 to 30 per 100,000 people.
And that affects men and women equally.
Overall pancreatitis incidence, yes, roughly equal. And it tends to hit middle-aged and older folks, average age around 40 for diagnosis.
But what about chronic pancreatitis prevalence? How many people are living with it?
That's lower, around 3 per 100,000 in the UK. But, the notes say prevalence is increasing.
Increasing. Why?
It's thought to be linked mainly to rising alcohol consumption levels. And for established chronic pancreatitis, the male-to-female ratio is more like 4 to 1.
Ah, so chronic affects men more.
Seems so, yeah. And the average age of onset is still around that 40 mark.
Okay, that frames the problem.
Yeah.
So what are the classic signs and symptoms, the clinical features someone might present with?
The absolute hallmark symptom is usually severe abdominal pain. Typically upper abdomen, often boring right through to the back. It can be relentless, really impacting quality of life.
That sounds awful. What else?
Nausea, vomiting are common too. Loss of appetite is a big one. And then as the pancreas fails, you get signs of exocrine insufficiency.
Which means?
Malabsorption. The body just can't digest food properly. So weight loss without trying, diarrhea, and that classic staturia.
Staturia, remind me.
Those pale, loose, really foul-smelling stools. It's undigested fat, basically. Protein deficiency can also happen over time.
And the endocrine side, the insulin.
Yeah, eventually the insulin-producing cells get damaged too, leading
Yeah.
to diabetes mellitus. And on examination, the main finding might just be tenderness in the upper abdomen when pressed.
Okay. The notes also mentioned how an acute flare might look different.
Right. It's helpful to know the signs of an acute attack, as chronic patients can have these flare-ups. Think sudden, severe pain radiating to the back, vomiting, fever, nausea.
Any specific signs a doctor might see?
Maybe tenderness. But in severe cases, you might see bruising signs like gray turners on the flank or Cullens around the belly button. Signs of dehydration, too.
And knowing this helps understand the whole picture.
Exactly. Because chronic pancreatitis can develop after repeat attacks or just gradually. And the notes give that useful diagnostic guide. Usually need 2 out of 3 things: the typical symptoms, the right biochemistry, and CT findings.
Right, that triad. So let's move on to the tests, the investigations used to confirm all this.
Okay, biochemically, the key thing, especially in flares, is looking for serum amylase or lipase levels going way up, more than 3 times the normal upper limit is the usual benchmark.
And imaging. What's first line?
Usual CT or ultrasound. You're looking for those structural changes, calcification, or a dilated main duct.
What if those aren't clear?
Then you might move to more advanced imaging, MRI, sometimes with secret and stimulation to check duct function, or endoscopic ultrasound, EUS.
EUS, that's the scope with the ultrasound on the end.
Exactly. Gets really detailed pictures from inside.
Are there other blood tests done?
Oh yeah, especially if someone's quite unwell, say with a flare-up. You do a full blood count, check kidney function, UNEs, glucose, liver tests, calcium, CRP for inflammation.
And maybe arterial blood gases?
In severe cases, yes, to check oxygen levels and see if there's metabolic acidosis.
You mentioned CT earlier. Any specific type?
CT with contrast is often preferred. It helps spot areas of dead tissue, necrosis, and grade how severe things are. Often done if the blood tests are iffy or symptoms aren't improving after a couple of days.
And ultrasound is mainly for?
Good for looking for gallstones as a possible cause. Okay.
Any other imaging?
MRI can give good views of the bile and pancreatic ducts, checking for stones, or even a tumor. And there's a specialized version, secret and enhanced MRCP, which is great for looking at the ducts in chronic pancreatitis.
What about testing how well the pancreas is actually working? Function tests?
Yes, things like fecal elastase. Measuring that enzyme in the stool gives an idea of exocrine function enzyme production.
But the notes said early diagnosis can be tricky.
It can be, yeah. There isn't always one specific blood marker early on. The secretin stimulation test can assess function damage, but it's not done everywhere.
What else might be looked at?
Things like nutritional markers in the blood, serum trypsinogen, maybe a D-xylose test for absorption, and fecal elastase again. More invasively, sometimes fluid is collected from the duodenum during endoscopy.
Right. And for monitoring chronic disease?
Imaging is key. CT, that's secretin MRCP, and EUS are the mainstays. Biopsy is rarely done. The notes mention too risky usually.
So it really is about putting all the pieces together, symptoms, bloods, imaging.
Absolutely. It's a combination approach.
Okay, so once you have the diagnosis, how do you manage chronic pancreatitis? What's the plan?
Management is really about several goals: controlling pain, replacing the lost enzyme and insulin function, and trying to prevent complications.
Starts a lifestyle, I imagine.
Absolutely fundamental. Strong advice to stop smoking, cut down alcohol, ideally stop completely. And a low-fat diet is usually recommended to help with fat digestion issues.
And the pain, that sounds like a major issue.
It often is. Management is usually tiered. Start with medications, then maybe endoscopic treatments if there are duct blockages or strictures, sometimes nerve blocks, like a coeliac plexus block, and surgery is an option too.
What about replacing the enzymes?
That's PERT pancreatic enzyme replacement therapy. It's essential for most people with significant exocrine insufficiency. You take enzyme capsules with meals to help digest food.
And you need to monitor that.
Definitely. Need ongoing monitoring of both exocrine function to get the PERT dose right and endocrine function to watch for or manage diabetes.
When does surgery come into play more seriously?
Well, EOS can help guide procedures. Simple things might be done via ERCP, like removing stones or placing stents in narrowed ducts.
And bigger operations.
There are several. Surgical decompression to drain the duct, various resections removing parts of the pancreas, like the Ripple procedure, or procedures that preserve the duodenum, or Frey's procedure, which combines resection and drainage.
Sounds complex.
They are major operations. And in really severe intractable pain cases, sometimes the whole pancreas is removed, total pancreatectomy.
But then you definitely have diabetes and digestive issues.
Yes, but sometimes they could do an autologous islet cell transplant at the same time. Take the patient's own insulin-producing cells before removing the pancreas and transplant them to the liver.
To try and preserve some insulin function.
Exactly. It's an attempt to manage pain and maintain insulin independence, but it's a very specialized procedure.
Any newer approaches mentioned?
The notes briefly mention emerging things for pain, like radiofrequency treatment and spinal cord stimulation.
So it's a real multi-pronged attack. Lifestyle, pain control, peer, maybe endoscopy or surgery, and these newer therapies.
That sums it up well. It has to be tailored to the individual.
Given all that, what's the long-term outlook, the prognosis?
Well, it's a serious condition. It's definitely linked to increased mortality and morbidity. Things like continuing to smoke or drink or having advanced liver disease make the prognosis worse.
Are there survival statistics?
The notes give some figures. About 70% 10-year survival rate, dropping to maybe 45% at 20 years. So quite significant long-term impact.
Yeah, those are sobering numbers. And what about specific complications that can develop along the way?
Quite a few potential ones. Nutritional issues like vitamin B12 deficiency cobalamin, diabetes, as we discussed, which can be quite difficult to control, sometimes called brittle diabetes.
Prone to complications itself.
Exactly. Then you can get fluid collections around the heart, lungs, or in the abdomen, and specifically pancreatic fluid collections called pseudocysts.
Pseudocysts, what needs doing for those?
They might need draining, often along with bowel rest. There's also a risk of bleeding, say if a pseudocyst eats into a nearby blood vessel or the bowel wall.
And the really big concern?
Pancreatic cancer, pancreatic carcinoma. The risk is definitely increased in people with chronic pancreatitis. That chronic inflammation is thought to be a key driver in developing adenocarcinoma.
That's a very serious complication. Okay, let's try and pull that all together. We've seen chronic pancreatitis as this ongoing inflammation causing irreversible damage.
Driven by various things, alcohol, smoking, genetics being major factors.
We looked at how it damages the pancreas, the different types, what else it might look like.
How common it is, particularly affecting middle-aged men increasingly, the key features like that awful back pain and digestive upset.
The investigations from bloods to scans, and the really comprehensive management needed lifestyle, period, pain control, potentially surgery.
And finishing with the tough prognosis and those significant complications, including the cancer risk, it's definitely a condition with a major impact.
Absolutely. And perhaps, thinking ahead, maybe the provocative thought for you, the listener, is this. As we get better at understanding that complex web of genetics, lifestyle, and what's happening inside the pancreas,
perhaps we'll see earlier detection become more common, and maybe even more targeted therapies that address the specific underlying mechanisms in each person.
definitely something to hope for, and an area needing much more research. If this deep dive has helped your revision or sparked your interest, remember to check out PassTheMSRA.com.
And FreeMSRA.com too, both great resources for learning and revision.
Thanks for joining us today for this deep dive into chronic pancreatitis. We'll catch you on the next one.